we're very lucky tonight, well I think that we're very privileged tonight to have a talk which is particularly of relevance to Lochaber and something which I've personally taken interest in for a long time. But I'll come to that in just a moment. We may find out tonight that the National Health Service started in Ballachulish, but very pleased to have Dr. Miles Mack come down from Inverness. I don't know Miles well, although I do remember when you were a trainee, at the same time Anna Bryan, who was a trainee of ours, and she spoke very fondly of you, an Irish girl. Miles was making his mark then, and indeed he's continuing to do so. And tonight he's going to talk about the Highlands and Islands Medical Service Committee report of 1912 and put into place Lochaber and indeed the Highlands in the development of the health service, and I think progress on to talk about its relevance today.
Absolutely, I hope so.
Thank you. Miles.
Thank you very much. Well, it's lovely to be back. Last time I was here, I spent a week here in 1994 learning to be a GP trainer. It seems a long time ago, and it was fond memories then, so I'm glad to be back again today. I'm glad to be in Lochaber because, as Chris says, it has very strong links to this project, which has become somewhat of an obsession of mine. And if anyone's looking for anyone to blame for that, this is Chris and Jim Douglas's fault that I've been infected with this, and I'm amazed at. Yeah, my wife is getting quite intolerant of the whole business. But anyway, this report came out in 1912, and there's a group of us who got together to really celebrate the centenary and to tell the story. And I think we've had quite a successful time in doing that. And I want to share some of that story with you and what we've done with it since then. So that's the plan tonight. I'm a GP in Dingwall. I've been there nearly 20 years as a partner, and it's been fascinating to connect with some of my predecessors in Dingwall through this work. I think that's been one of the really intriguing things, to realise that as GPs, and I know some GPs in the audience, that we've been handed on a baton, and actually to realise just exactly how important that baton was to not just the Highlands, but actually wider than that. I'm going to start just with a bit of background to where this really came from and why there was a Dewar report in the first place. The Highlands, I'm sure I'm talking to the converted, but for me it was this business of 1845 with the problems of the potato famine, the Poor Law Act coming in, making the first start to get some sort of cover for the very poorest echelons of society, and just trying to work out how this all came together. Some of this is relevant to me. One of my predecessors was William Bruce, and he was a doctor, a first medical superintendent for the Ross Memorial Hospital in Dingwall. And again, all these characters keep on cropping up. I don't know if any of the audience has had polymyalgia, but William Bruce was the first person to describe it in the BMJ. He called it senile rheumatic gout. Everything was gout at that time, particularly in Dingwall because we were close to Strathpeffer. And had all connections with rheumatology, and you can see why this all developed. But part of his work, he also provided cover under the Poor Law, and this is his receipt in the top left-hand corner for covering some of the paupers in Rootfield, one of the local parishes. At the same time, soon after that, there was a Poor Law. There was actually a very important report. One of the first reports looking at the medical services in the Highlands in 1850, the Coldstream report, which was published by the Royal College of Physicians. And again, I'm afraid it's a bit more of my local hint. This is from content, also in our practice area, on the bottom right-hand corner. And this was some of the evidence given to that report. And good old Reverend Downey was asked, is there any complaint amongst the people of inadequacy of supply of medical aid? And he responded, not that I've heard. Indeed, some of the people, especially those in the mountainous areas, have an ignorant prejudice in medical aid. Now, we suggest that actually the ignorant prejudice was maybe somewhere else, but actually these people weren't working, didn't have a cash economy, and it was incredibly embarrassing for them to be calling on medical aid when they had nothing to provide in return. And actually, there was a great deal of evidence which was picked up in the report even in 1912, of alternatives to that, of folk cures and others, ways to get some help. It also tied into some of the crofting reform, the land reform problems. I'm afraid, again, from Mulbury, just above my house, I didn't realise that after the Battle of the Braes in 1881 and the Napier Commission in 1884, the first Highland Land League Reform Association was actually held in Dingwall in 1884. And people marched from Mulbury into Dingwall, and I understand some of them were locked up. And these were just some of the pockets of activity all over the Highlands. It wasn't just in Skye and some of the more publicised areas of actually people just striving to get some land tenure, which was carried on through. The Highlanders were seen as quite an important bunch. As a result of the Highland Land League, I understand that with the increasing franchise of the vote, lots of the Highland Land League party people got elected. In fact, almost all of the Highlands taken over by Highland Land League party, and they got incorporated into the Liberal Party. So we get this picture that actually the Liberal Party, who were in power in 1912, owed a great deal and were worried that they might lose some of that support from the Highlanders. In addition, so the whole idea that the medical problems and the ideas that people weren't getting the care came up again. In 1904, there was a survey just looking at the Paupers Act and seeing how it was working. For those, these to be counted as a pauper, you really had nothing. These were the only people who were provided with any medical care. But the big problem was that put a big charge on the local parochial council to actually provide medical care for them. In 1904, they did a survey of this, and some of the evidence, with Dr. Mackenzie of US said, frequently pointed out already, the want of sufficient medical and nursing attention have a most prejudicial effect on the well-being of the district. The loss of life, hardship and misery which this implies cannot be calculated. To a certain extent, the physical evil is evident, while it tends to produce a callousness of suffering and death that becomes only too apparent in the number of uncertified deaths, especially amongst the aged. This was beginning to gain some momentum as a social issue, and the Highlands were beginning to come to attention, actually the situation that was there, and very different in other parts of the country. They were also looking to the Highlands for medical recruits, and the quality of the recruits was beginning to become a national issue. So when the Liberal Party needed some extra support, the time came to do something about that, and actually to try and address some of the other social needs for the Highlanders became a little bit more important than would have been otherwise. This is when Newsland came into it, and this is Sir John Dewar, Liberal MP for Inverness, and a whisky magnate and a benefactor of Perth. He was one of the Dewar sons, the two Dewar sons. His brother, Thomas Dewar, was absolute marketing wizard. He went around the world and drummed up business all around the world for the whisky. One of the first radio and one of the first TV adverts were done by this family, and they made a great deal of money. This man was at home running the business and making sure it worked. He was twice Lord Provost of Perth, and a leading Liberal politician. He'd been knighted in 1907, so he was obviously a bit of a coup to lead this committee. The committee was a number of people on it, and Sir John Dewar was leading it. Marchioness of Tullibardine was convener of the County of Zetland and Sutherland. There was Leslie Mackenzie, who was a medical member, and a local government board for Scotland. We'll come back to Dr. Millar. There was Dr. Robertson, who was actually a lawyer, and Chief Senior Inspector of Schools for Scotland. They really did get some pretty hard-hitting people together for this. I mentioned Dr. Millar. Dr. Millar's in the TA uniform, sitting at the bottom right. He was a Gaelic speaker, born and raised in Fort William, the son of a baker, I think. Did extremely well at Edinburgh University, graduated with the highest honours and became medical officer for Fort William. In addition, he was a consultant physician at the Inverness Sanatorium and the surgeon to the Belford Hospital. He was a member of the Caledonian Medical Society. This is the Caledonian Medical Society, and this is a picture from 1912. This organisation started off as an organisation for undergraduates at Edinburgh from the Highlands, and a way of networking. And as with a lot of these things, those networks became extremely powerful and influential. And by 1912, they had their own journal, they were meeting regularly. And in fact, Sir John Dewar had been asked to their AGM 2 years before, in 1910, here in Lochaber. We're getting the picture that quite a lot of the main people who spoke at the Dewar Report were part of this organisation, and it sounded like networking was important then as it is now. They just did it in a different way. Some of Dr. Millar's evidence is amazing, and some of the things that are written about him. He gave an extremely gruesome account of the death of some poor railway worker who'd been transfixed by a crowbar and took 3 weeks to die. And incredible what was going on at that time. Inevitably died of infection. I'm sure may well have had a different outcome now, even though the crowbar went in from the right thing and came out through his back. There are other local people. This is one of my favourite people, is Murdoch Beaton. He was asked to be the secretary for the committee. He looks every part of the Edwardian gentleman, but in fact the situation was somewhat different. He was born in Ardell on the shore of Loch Dewar, close to Donnan Castle, although obviously it was ruins at that point. It looks like his father was actually illiterate. We look at his birth certificate and his mark with a cross. But he was obviously noted to be a bright lad, and was picked to go off to Aberdeen Grammar School with the idea of joining the church. Things didn't happen that way. He got interested in Shinty and the chanter, and that sort of precluded him from a career in the church. And in fact, he brought his chanter back to show his father. Apparently his father broke it over his knee. So we looked for other employment, much to our benefit, I believe, and it was traditional, as was often the case, it was in teaching. Became a teacher, but soon became a chief inspector, became an inspector of schools, travelled widely. His Gaelic speaking was of great use to him, and in fact went out to St Kilda in 1905, 1907 to see how things were there. So at the time of this report, he was an inspector under the National Health Insurance Commission. He seems to be an absolute key person in writing this report, and we've got copies of it here, and we've also got it online. It's written in the most beautiful English, which makes extremely easy reading now, and I'm sure was key to its success, to what it demanded. I mentioned briefly the Marchioness of Tullibardine. She's quite a girl. She was born Kitty Ramsay and educated in England, and was a prominent citizen, collecting many honorary degrees, including from Oxford and Glasgow, Manchester, Leeds, Durham, McGill and Columbia. In 1899 she married the Marquis of Tullibardine, son of the Duke of Atholl, and she was invited to be a part of this committee, which we think is reasonably remarkable and very much a sign of the times that actually they did ask for a female member. And she added a great deal. A lot of her inquiries in the evidence are to do with women's and children's health, which is absolutely the course that she ploughed through the rest of her career. They said that how they got their evidence, they actually started off by just doing a search of previous evidence and records. But soon after that, they actually headed off out to visit the area. Started at Inverness in August, went to Thurso, Kirkwall, Fair Isle and Lerwick, and then stopped for September because it was the shooting season. Now, actually, I think that was probably pretty shrewd, because this was the one time the doctors in these areas would actually get any private income. So they really had to back off, although I'm sure they all went off shooting too, and came back in October and started again, which must have been quite something with the conditions of transport at the time. So they carried on going to Legg, Betty Hill, Reconick in Sutherlandshire, off to Stornoway and Garranaheen on Lewis, Tarbert and Harris, Lochmaddy in North Uist, then across to Dunvegan and Portree in Skye, before going down to Cardiff, Perth, Oban and Edinburgh and Glasgow. The evidence is fascinating, and it's really it's great fun to actually go to your local evidence. It's fascinating to find out, for instance, about the Seaforth Sanatorium in Maryborough, right close to us, which we are still visiting. It's now a care home. This was a TB sanatorium, and the medical officer there has only been in post for a few years, and that sanatorium was providing care right the way across Rochester, including Lewis. And all sorts of information came out about the local personalities in each of these areas, and it's been intriguing to see what's happened. But of course, particularly key was some of the evidence from Lochaber. We've got some lovely pictures of them on there. This is from the Dewar family archive up at Reconick in Sutherlandshire. They hired a boat or a yacht to carry them around. They got into a bit of stuck for that because Edinburgh, needless to say, didn't really understand. They also got into trouble for wanting to employ the secretaries for every day they were away. Edinburgh just wanted to employ them for the time they were taking minutes. But of course, this was completely inappropriate for the conditions at the time. And obviously things have changed. I think this picture is stored way down at the bottom. And some of the evidence in Lerwick, one of the people they spoke to was a Reverend Fotheringham. And this is just some example of the sort of evidence that was coming forward. Reverend Fotheringham actually started his medical career, but couldn't continue. He didn't have the money to continue it, so he ended up in the church. But poor man was quite often asked to cover for Dr. Imrie's absence. Dr. Imrie was often called out to Fair Isle. There were real problems about getting out there and getting back. Poor old Dr. Fotheringham was aware even then about the problem actually providing medical care and actually the risk of getting sued and all this business. There were times when he'd undertaken surgery on patients in Dr. Imrie's absence because there was just no one there. I think it was to a certain extent the initiative and the resilience of the populations to cope at this time was quite startling. Transport was a big issue. There was the doctors often weren't able to afford any motorised transport. The idea of motorboats being able to get out and back to Fair Isle in a reliable way was seen as quite a revolutionary and important step that needed to be taken at the time. Yes, other bits of poor old Reverend was also asked about the predecessors, Dr. Imrie's predecessors. He said one of them was not very steady, and he was exposed to the weather, but he did work very thoroughly. The other was weakly. They both died as a result of exposure. And we get all these ideas that actually some of the medical personnel had problems, and I suggest that alcohol often played a part at that time, and these doctors were in a pretty parlous state. I find it quite difficult to take that. Dr. Millar was present when someone else was, when Dr. Lachlan Grant was called. Now, Dr. Lachlan Grant, is an absolute hero of ours, and Jim Douglas has done a great deal to raise the awareness of just what this man has done. He was born in Johnston, but moved to Ballachulish as a young man. Also went off to study at Edinburgh and graduated in 1894, again with distinction, and found a job at Gesto Hospital. And there was stiff competition for this post, because this was one of the posts which actually was funded, and the doctors going there could get a reliable income. And it was thought of as a plum job for people coming out of medical training. He did return to Ballachulish and had a fantastic career there. I'm sure you all know, do know that he was dismissed in 1902 because of his making a fuss about the working conditions of the slate quarriers. They came out of strike for 18 months before he was reinstated. Some of this action has really changed the whole face of employment relationships at that time, and was just a mark of the man who was absolutely committed to the care of his patients. In the medical side, he was particularly committed to bacteriology. This was a hugely increasing science at that time, and was completely revolutionising the way they were treating TB. He actually provided laboratory services for the practice nearby as part of what he was doing. He was very keen on vaccination and health promotion, and very keen to get comprehensive cover to the patients in his area, and he did that with a workers' medical club, which he provided some sort of oversight to, although this was very much run by the workers, in a model which was seen in other parts of the country as well. Even some of the bits, his evidence, we talked about frivolous calls, things that as GPs we sort of slightly spot some recognition about that, but equally the whole problem about that versus not being called at all. He was just as anxious that people weren't going to call him because they had no access to paying him and no access to any form of attention. He provided amazing detail to this report, and his answer was really that what you need is a full state medical service for our Highlands and Islands. A lot of what he proposed seemed to be very close to what came out in the Highlands and Islands Medical Service. A lot of his evidence and lots of his suggestions came through in that way. And actually looking at it, it doesn't seem that far different to what came out in the NHS. We'll go back to those links a bit later on. He even had concerns for quality of medical care, and you're probably all aware that we're going through, as all of us as doctors, we're going through a process of having to undertake 5-yearly revalidation. It's probably taken this long before it's actually come into place, but Lachlan Grant was talking about it even then, about how to ensure the quality of medical care was consistent and could be seen to be okay in small community areas. He continued to practice in Ballachulish. He did a lot of research-led practice. He did a lot of research about the health care of the slate quarriers, and later on about the aluminium workers in Kinlochleven. And his evidence seems to have assured people that aluminium was safe many years before all the worries that we've had more recently about the risks of aluminium and dementia, which seem to be unfounded. Not only that, he got involved in the land question. He published on that and also on Highland immigration. He was desperate that our young population shouldn't be leaving the country and thought this was a really bad idea. And he actually started to gain momentum for the New Deal in the Highlands, which eventually came to fruition in the Highlands and Islands, of the Highlands Island Development Board after the Second War. So he became quite a leader in the politics and administration of health and health provision. And he was a vocal champion for his community. This is him immunising a child outside this croft house. I think it was very much the practice because it was too dark to properly see them. I've got memories of even my early career going to a croft house where I had to really keep going with the history long enough for my eyes to get accustomed to the gloom in a house without electricity, before I could vaguely make out this gentleman under this big pile of blankets. Had a telephone, but no toilet, no electricity, and it was a great deal of palpation and not very much inspection to make a diagnosis. So I have some sympathy, I couldn't get my patient outside. This is a picture that's Jim Douglas has got commissioned. It's now hanging in the Royal College of GPs in Edinburgh. We believe it represents some of the things that Lachlan Grant has brought, and actually the lasting legacy it has, not just in medicine, but also in industrial relations and the whole communities of the Highlands. The report was published on Christmas Eve of 1912. Unfortunately, not great time for us to celebrate it. I'm not sure anyone would really want to come out and party on Christmas Eve to celebrate this report, but we certainly think it's worth celebrating. It was split into a number of sections. The first bit was about the state of the medical services. And I'm just going back on this, the doctors had no security of tenure and could easily be just dismissed at the moment's notice. Inadequate housing and inadequate income. Money was very uncertain about where it was going to come from, and was reliant on a number of different streams. So it was really unclear that actually paupers could become quite important people in the community. Poor old Papa Westray had one pauper, and because of that they had to find £70 a year to employ a doctor to look after this man. And you realise that actually if that person disappears, then it actually has major implications for the rest of the community. Although probably the landowners who are paying the most of the rents would decide a relief. It wasn't just that, there was transport and telephone systems were poorly developed. A lot of areas were just on telegraph. Where there were telephones, they weren't necessarily linked together. And there was all sorts of suggestions to really an idea of using almost like what we now using telephones. When we're starting to use internet and Skype, they were just still starting to use telephones that a nurse could consult a doctor at a distance, and try sort of ideas of telehealth which are developing now. There was a great deal of evidence of inadequacy of medical attendance, and for me the most shocking bit was about death certification. It was mentioned a little bit earlier, but actually in the county of Ross, in the 10 years previously, over 47% of deaths went uncertified. So that even at the time of death, even across the whole of Rochester, that included Dingwall and the Black Isle, which were relatively prosperous, people at the time of death weren't getting a medical cause for death because there was no doctor who had attended them. Now in Coigach on the west coast, it was up to 80 or 90%, and this was a picture right the way across the patch. The rest of Scotland was only about 2%, so there was a real big difference there. Many accounts of doctors being called too late or not at all, and there was awareness that the patients just weren't in a position to afford to pay a fee. All sorts of ways around that. There were stories of doctors being called to a pauper and spending ages getting to this man 10 or 15 miles away, getting stopped on the road by all sorts of people. And finally the pauper really had not a great deal wrong with them. And it almost was a ploy, and it almost became a game that was played. There was a great deal of resort to quack medicines of American manufacture, and together with a reliance on traditional cures and superstitions. To the extent that actually there was accounts, even at that time, if someone a cure for epilepsy was to bury a live black cock at the site of the person that had their first fit. And they did this with great ceremony in the Sunday best, well out of the sight of the minister, and this was what they relied on as a cure. They also made a case for exceptional treatment. This is them visiting. This is from the family archives. This is the committee visiting a Black township. It describes a sparse population, wild landscape, and rudimentary road network. Many people were miles from the doctor, and there are examples of doctors putting their own safety at risk to attend to sick patients. In fact, one doctor got the Carnegie Medal across from Lagan. He went into Ben Alder Cottage, where I don't know if anyone knows that, over the top of Ben Alder, because he couldn't get round because the lower slopes were too icy, to attend to this patient with pneumonia, and became pretty ill on himself as a result of his exertions. There was other bit about the housing. The houses, this evidence from the report, were practically only one room with damp walls, damp clay floors, sunless interiors, and vitiated and smoky atmosphere, and the cattle under the same roof with the human inmates. The surroundings usually badly drained and the site often damp. When a case of phthisis occurs in one of these houses, isolation is impossible. In too many cases, the patient spits on the floor of churches and meeting houses, scattering the tubercle bacilli all around. When one considers also the probability of cattle being affected with tuberculosis under the conditions prevailing, what else can you expect with the wide prevalence of the disease? People were moving backwards and forwards to urban areas, and TB was coming in quite a lot. As soon as it was reaching into these sort of communities, it spread widely. We talked about depopulation. This was still continuing well into the early parts of the 20th century. And the local rates were inadequate to cover the cost of the doctor's income. I think this worked to the population's advantage to some extent, because it got some support from the landowners for some form of change, because actually it was becoming untenable for them as well. The Insurance Act had been reformed, but actually really provided no assistance to Highland population. Many people in these communities, or the only people in these communities who often could afford the insurance, or actually were in paid employment, was the minister, the teacher and the doctor. The rest of the people, as crofters, had no regular paid employment to benefit from the National Insurance Act. And the government became increasingly realised that. Sorry, more pictures. This is Lochaber Hospital, which is still in use. Talked about the provision of nurses in hospitals. They went into quite a lot of detail about this. Actually, the total number of nurses was quite low, and it was completely arbitrary where they were distributed, where they were based. They relied a great deal on philanthropic activity, so that some estates would provide a nurse, but the nurse was very limited about what patients they could attend to, and they may well have ended up being stuck within the estate area when people were a lot more sick just outside of it. The nurses were also thought to be incredibly important for follow-up of treatment and continuing treatment. The idea that you just go in and do something wasn't recognised, and realised that actually people needed support in their houses. And actually as sources of good hygiene and domestic knowledge was also important to the nurses were providing a great deal of role on that side. So he recommended a reorganisation of the nursing service, building of community hospitals, improvement of telephones, and provision of ambulance services. This is pictures from a little bit later, and we think this is the first nurse to be provided with a motorbike, and obviously made a huge difference to her travelling. The overall, the end result was that they suggested that an imperial grant should be provided to enable the reorganisation of the medical service under a single organisation, with patients paying a small fee for services and doctors receiving a minimum salary with additional expenses for travel. In effect, in the more remote areas, the doctors really didn't expect to exceed that amount with any fees, so the fees tended to get waived. In places like Dingwall, they probably did take in the fees, but then they were always guaranteed a reasonable income, and they actually got something back for the travel expenses. This is a copy of one of the posters at the time in Argyll, advertising to the population how they should take advantage of this new service. It took a little bit of time to get going. Obviously, the First World War got in the way of that. They made some early gains. They provided a nurse to St Kilda in 1914, and they also provided a grant to the hospital in Fort William, the Belford, to prevent closure in 1960. It didn't really start getting going until about 1919, when control moved to the Scottish Board of Health, but things moved very quickly then, particularly as far as forming nursing associations. Communities all across Scotland did that to get advantage of nurses, funding for nurses, and that revolutionised things. That very quickly became a planned provision of nurses across the Highlands. The McMaster report sort of seems to reinforce the idea that we should have personal service, such as can be rendered to people in their own homes only by a family doctor who has continuous care of their health. And this seems to build into this picture of general practice and medicine developing at that time into something quite close to what we have now. In addition to the doctors, the GPs, the first consultant appointment was the general surgeon to Stornoway Hospital in 1924. And the district nurse, by 1929, talk about district nursing associations, there were 73 established, employing 175 nurses. So really quite a big establishment. In 1934, consultant surgeons were established in Shetland, Orkney and Caithness. Before that, a bit like Dr. Millar, he would be providing general medical care and also acting as a surgeon for the hospitals, and it began to become a little bit more specialised. But even it resulted in the first air ambulance in 1936 to the Western Isles. Before that, a couple of years before that, was the first time an aeroplane had been used to evacuate someone to Glasgow. We get an idea of what sort of effect this had with the Cathcart report. The Cathcart report looked at medical services across Scotland in 1936. And they said this, they were talking about Highlands and Islands Medical Service. This service has revolutionised medical provision in the Highlands. It is now reasonably adequate in the sense that for all districts, the service of a doctor are available on reasonable terms. This is a picture of the Gorbals. And in fact, in a lot of urban areas, there was clamouring to have something similar to the Highlands and Islands Medical Service. Certainly in South Lanarkshire, they were wanting access to the same sort of service because they had just exactly similar problems in inner city problems at that time. And then things did move on. The Beveridge Committee we all know about in 1942 was obviously, and actually we really weren't quite sure how we could tie the link, but then we found we struck gold, because actually one of the members of the Beveridge Committee was a Miss Muriel Ritson, CBE, and she was at the Department of Health of Scotland, and she'd actually been an administrator for the Highlands and Islands Medical Service. So we've now got clear evidence that all those similarities between the Highlands and Islands Medical Service and the NHS, we've got clear evidence that they had direct experience of the Highlands to draw upon when they were forming the NHS. So in 1948, the NHS took over from the Highlands and Islands Medical Service, really in a very straightforward, calm way. There was a certain amount of scurrying around for patients. I know my predecessors had patients in Gairloch from Dingwall. I don't know how they managed, but that idea of just getting as wide a base as you could was important at that time. But really, the whole appreciation of the NHS, the Highlands and Islands just morphed from one to the other. Some of the personalities, this is Sir John Dewar. He retired from Westminster in 1917 and was elevated to the peerage as Lord Forteviot of Dublin, the first of the so-called whisky barons. He died in 1929, left an estate of £4.5 million. He was described as the founder of the company, a chief shaper in its destiny, a man of kind and lovable disposition. The interesting thing was that actually their own archivist was almost unaware of Sir John Dewar's work in our report. And it was fascinating to be able to fill them in because he had done so many other grand things in his life. Good Marchioness of Tullibardine became the Duchess of Atholl in 1917 when her husband's father died, and he became the Duke of Atholl. She actually attended anti-suffragette meetings in Glasgow in 1913, believing that women needed more experience in local government before they got to the parliamentary vote. She was considered quite eccentric in the promotion of the rights of travelling people on the Departmental Committee of Scottish Tinkers in 1917. But by 1920, we think she sat on 25 committees, 12 of which were education committees. So she certainly practiced what she preached when she became the first female, the first Scottish MP in 1923 for the Kinloss and West Perthshire constituency. She was also the first woman to serve on a Conservative government, but didn't always have an easy time of it. She twice resigned the whip, and in 1937 she went with two others to Spain to observe the effects of the Spanish Civil War, and she came back with the nickname the Red Duchess thereafter. She resigned her seats in Parliament in opposition to Chamberlain's policy of appeasement, and even in 1945 she was campaigning against Soviet control of Poland, Czechoslovakia and Hungary. She died in 1960 at age 85. It seems to have been quite a while. I think she also made a mark in the Dewar report. Murdoch Beaton had been in the TA at his university and was quickly called up in the First World War. He was promoted to Lieutenant Colonel and became the commander of the 4th Battalion Cameron Highlanders. Following the war, he came out, he rejoined the Poor Law Commission and was actually involved in the evacuation of St Kilda in 1930. He then moved to Edinburgh and died aged 79 in the 3rd of February 1948, so just 5 months before the start of the Scottish NHS. I don't know what you'd think about that, but I'm sure you've seen some similarities. One of the joys of being involved in this sort of work was the links that you make. I got this wonderful email from a Dr. Neil Beaton. Now this is Murdoch's grandson, who's now living in Australia. And he'd just written this report on similar problems in rural Queensland, and dealing with the same sort of ideas. And it was really heartwarming to see that his grandson had been involved in similar things 100 years later. And it was a really wonderful email to get. It's been a great year to be involved in this. We started in Ballinasloss and Ballachulish, recreating one of the pictures of the Dewar community. This is some of us anyway. When we got together for the first time at a Lapland Grant Conference, and it's been intriguing to see how things have worked out. One of the key points was a members' debate on the centenary of the Dewar report, when Nicola Sturgeon suggested that this is a bit of Scottish history that she felt that every Scottish child should know about. As a result of that, we've been involved in looking at the problems of remote and rural medicine now, and there's been a great deal of work ongoing with that, particularly with Jim Douglas, really trying to use some of the things that worked with Dewar in the present day. Many of the problems are the same. We're still finding that populations are going down. We're still finding that infrastructure is a problem. Okay, we've got cars and we've got roads, but we still have main trunk roads without a white line down the middle with a single track. We've still got problems with rural broadband. We've still got problems with rural mobile phone networks. And actually, much the same way that Lapland Grant saw the problem, that we need to look a great deal wider than just plonking a doctor in an area and expecting things to be fine. It's been a fascinating. We've had conferences that we've set up ourselves in May. We've attended the Royal College of GPs conference in Glasgow and provided an event there. We've had some media exposure on STV News, and I was interviewed for BBC Broadcasting House on Radio 4. We've had exhibitions touring around the area. I think we've had one of it's been coming to Lochaber. We've been working closely with historians. Annie Tindley is a senior lecturer in the Glasgow Caledonian University. We've also got an archivist from the University of Dundee, and they've provided huge richness to our work. It was fascinating meeting them for the first time. They were slightly sort of stand-backish because we were the doctors and we knew what we were talking about. But of course, we felt we were very stand-backish because they're historians. They knew the story, and we were really we're all playing catch-up. But the two of us did as a group together, and we've got doctors from the Outer Isles, Rossshire, Inverness-shire, Lochaber, the Borders, Arran, all providing input and tying in with a great deal of academics with all sorts of other information. It's been an absolutely fascinating journey. We've put in articles on Wikipedia, updated them as necessary, and tried to provide a unified resource. We've got the reports on the internet, but we're working to get the full evidence on the internet as well in a searchable format. Because at the moment it's quite difficult to actually find the evidence for your own locality, and we feel this is a hugely important resource. It really is evidence of what was happening in the social circumstances of 1912 at this key moment in Highland history, when a transition from, one of the transitions towards what we see in the Highlands today. This is, I love these pictures that were posted by Applecross, seeking this on their Facebook page. And I really like the ingenuity of the community as a way of recruiting a doctor. They've been through the business of doing it by inviting the press in, but of course the press only wants to report the bad story about how difficult it is and what a problem being a doctor in an area is, which actually only gives it at the best the short-term answer. And they were really quite effective in this publicity. I talked about some of, there's been a proposal for a specific model on how we can look at remote and rural medical care now. And this is beginning to move on with actually a reasonable pace. This was started off in Nicola Sturgeon's tenure of health remit, and Alec Neil has taken it on. We're quite pleased to hear. It's quite a difficult job to tie things all together, and actually I think that there is benefit on us coming in really as people without necessarily such vested interest, and really the basis that we come in is because of our history and because of where we've come from. But we feel there's a great deal to learn from the history, and as a result of this, NHS Highlands has been asked to put forward a proposal which I believe has gone in, and we're beginning to trial some of our ideas in that basis. One of the things, I'm afraid I'm responsible for this. This is my mind map of some of the issues for remote and rural medicine now. Hugely complicated. Actually, I'm not going to apologise for that, because it is complicated, and anyone who thinks it's straightforward is actually missing the point. Huge amounts has been done for education and training needs for doctors, and actually pretty successfully. NHS Education Scotland has done some really good work on that. But actually there's all sorts of other areas that we've really not managed. And one of these ideas about domestic logistics, which was covered in Dewar, about where the doctor's going to live, what's his wife going to do, what about the secondary schooling for the kids, is absolutely live now. And we feel that actually we need to look at the whole picture. And it's not just about practitioner isolation, but we can't ignore that practitioner isolation is a problem. I would be lost without my colleagues in my big practice in Dingwall, and this is a real issue. And you see it in the results to what happens to some of these doctors in small communities. It's also about what GPs bring to the community. It is about leadership and advocacy, and actually the community's identity is quite often tied in with having a surgery, in the same way it is with having a post office or a school or a church. So this has been great fun to put that together, all sorts of feedback and moving things around, and it's been one of the strands that's been particularly effective. Jim Douglas has also got a system of bench testing for possible solutions and working out some really robust way of looking at some sort of solutions to these areas, and then stressing them. What happens if there's a gale? What happens if people are off sick? Is there resilience in the system, and is it actually going to be lasting? And the other bit is actually about the historical bit. How does this tie in with some of our core values that we've been handed on as doctors? And these core values are important, and there's a real risk that some of those might be lost, particularly with evidence-based medicine looking at actually going through clear pathways of care, which all looks very well, but may well be missing the point of actually some of the things that we really feel is important in a one-to-one long-term relationship with patients. So this was the committee in 1912. Been a fascinating story, just fascinating to find out more about them. I feel hugely enriched knowing about them as far as what it means for me as a doctor, with William Bruce and some of his successors. It made me really feel that actually what we have is really important. And it does, and this whole business of, I'm not a Highlander, as you can tell. I've only been here for 35 years. But I don't come with this the Highland anti-syzygy idea that I can't understand why the only thing gets talked about is Culloden and Glencoe massacre, when we've got so much to be proud of. I think this is something which we really do need to be proud of. I think this is something that we should be shouting from the heights. And the particular thing about this is that many of the solutions to healthcare which are invented in rural areas, we can export to other areas. Now, the opposite is not the case. So actually, the Highlands having a voice is hugely important, because we've got a lot of very important historical precedents for providing a basis of care, which I do believe there's a great deal of what happened in Lochaber and across the Highlands and Islands has had a lasting effect in the NHS, and is actually something we should be very proud of. Thank you very much.